Hello, everybody, again. I'm sorry I was mute. That always happens. Good afternoon, and welcome to our second webinar of the NLAAD 2024 series. This is the 22nd year, 22nd event, 22nd campaign, 21st year. Last year we celebrated 20 years. And this time we're having 5 webinars. So this is the second one with our team from the Department of Research and Innovation of the Latino Commission on AIDS. And we're going to present about the new diagnosis and HIV diagnosis in Texas. Here it is. My name is Alberto Males. I'm the Director of Community Mobilization Programs at the Latino Commission on AIDS, based in New York City, but with a reach to the entire country. By end, I also the Director of NLAAD, who is part of the program. I'm here happy to welcome you to our 2024 NLAAD campaign. You should have received earlier, past week or maybe 2 weeks ago, email with all the posters of this year's campaign. This year, we're focusing a lot on treatment. We want to make a remark that this is accessible for everybody living with HIV, but unfortunately for our community, the Latino community, we do not have all the access necessary. So we're going to see this in the posters, on the website, and the webinars that we are presenting. So today, as I mentioned, we're going to present our findings that our new team in research and innovation has found in Texas. We're doing Daniel is going to explain that more, but we're doing a research and investigation in the south of the country where the epidemic has shown to be more prevalent. So the team started with Texas, and this is a presentation about what we find in Texas. First, housekeeping, this webinar is being recorded. Please write your answers in the question and answer box that you should see in your screen. When you were logging in, you were muted automatically. If you need to talk, just raise your hand and send me a message, and somebody in the team, either Belly or Rosanna, were here also. We'll help you with that. When the webinar is finished, you will receive a survey at the end. It will open in your screen. Please fill it and send to us. We will very glad to receive it because we need that information to plan future webinars. With this, Daniel Castellanos is the Vice President of Research and Innovation at the Latino Commission on AIDS. He initiated his career in 1995 as an activist. Daniel co-founded the Colombian Lesbian and Gay Association in Queens Pride House in New York City and oversaw the HIV-related services for sexual and racial ethnic minorities for over 20 years. Daniel obtained an MPH, the doctorate MPH degrees from Columbia University. He has trained faculty and health officials in developing evidence-based interventions, including at Columbia University, the University of Puerto Rico, and the Mexican National Institute of Public Health. He has researched LGBTQ youth homelessness, HIV prevention, sex work in the Dominican Republic, and LGBTQ and HIV activism. Currently, his work includes COVID-19 impact on organizations of colors, the under-utilization of behavioral science services, and the integration of HIV in aging services. I have to add, Daniel Castellanos is a very important part of the Latino Commission AIDS. He plays a very important role, and he supports a lot of programs within the community and the commission. His team has been doing research in the south of the country. I think they're doing something further now. He started with Texas, and we'll continue with other states together with our team in the south. And now, Daniel, you are welcome to continue your session.
Thank you, Luis. Just checking. Can you hear me? Can you see the presentation?
Yes.
Okay, great. Hi, everyone. Thank you for being here. So today we are going to be presenting some of the work that we have done for the past 3 years. We are going to present some data that is actually public data, and that's very important. And also we are going to talk about the experience over the last 3 years traveling across Texas, partnering with these organizations and many others, community service organizations, health departments, research institutions, academic institutions, and community leaders. As you can see, this is the map of Texas, and these are some of the cities that we have traveled to for the last 3 years. We have visited every city about 3 times, conducting focus groups, collecting surveys, and also meeting with local leaders and doing listening sessions. Every year we have travel across from the larger cities like San Antonio, Houston, or Dallas to the rural area in Lubbock or El Paso, and then many counties along the border. We are in Texas a very diverse community. This is some of our work that inform what we are going to be talking about today. We produced last year the socioeconomic health and socioeconomic profile, and we will be updating soon that profile. The QR code is there. Please check it out because it looks at HIV and other 5 health issues within the larger socioeconomic context. We have done also a mental health and substance use assessment. We're particularly looking at stigma health literacy. Go to our website and you will have some of that information there. We are currently, we just finished our preventative health system assessment. We travel to 8 cities, conducted regional meetings, and we will be doing one statewide meeting. And in progress, we are doing an assessment on integrating HIV and aging services for older Hispanics living with HIV. That's currently in process, and we want to thank all of our partners. A little bit about Texas. 1 in 5 U.S. Hispanics live in Texas, and that's up from 20 years ago. Texas is a young state in terms of Hispanics, and it's growing very fast. Hispanics represented 40% of Texas in 2022, and is up from 32 in 2000. In 20 years, you have seen a great increase of Hispanic communities all across Texas. Just for context, the 12 million Hispanic Texans exceed the total population in 44 states, DC, and Puerto Rico. The magnitude of the health needs and the impact that we can have in the Hispanic community as a whole for the U.S. needs to take consideration the needs of Texans. For context also, the Houston area, the metro area, is the 4th largest Hispanic metropolitan area, with about 2 million Hispanics living in Houston, in the Houston metropolitan area. So we are talking about a large number of Hispanics living in Texas. But Texas is also diverse, as we saw in the map. Even though Texan Hispanics represent 40% of all Texans, there is great variation from county to county. Here you have the 10 counties that we have focused on. The ones with the asterisk at the end are along the border with Mexico. And you can see that most of the counties have a proportion of Hispanics above the Texas average. What that means is that we wanted to focus on some of these counties. And you can see, for instance, that for Dallas, Harris, and Bexar County, which is Dallas, Houston, and San Antonio, 3 of the largest cities in Texas, the population is above the Texas average. So there's great diversity across these counties, and we are going to be referring back to this diversity, to this geographic and cultural diversity. So we are going to be looking a little bit early about the trends and inequities in terms of HIV. Then we're going to talk about the larger context in which those inequities happen. And finally, we are going to talk about some of the recommendations that we have been collecting over the last 3 years of work in terms of behavioral health, in terms of HIV, and also in terms of the preventative health system. Texas HIV outcomes. This is the latest data from, we included 2023 as preliminary data. As you can see, this is a long trend. We have seen in the news about the data from 2022, but in reality, this is a trend that has been going for a long time. Either the trend is flat, but it was flat, but in the last 5 years is growing up very fast. As you in the chart, over 50% of the new HIV diagnoses are among Hispanics. We also wanted to look at the rates for Hispanics in particular. Since 2008 to 2023, the rate has been particularly flat. However, the number of cases have increased. Uh, the preliminary data for 2023 is 2,762 cases. Most likely, those numbers are going to increase as more data come in. But that's troublesome in the sense that even though we are talking about a flat rate, these are people behind these numbers. And that's one we want to convey that we are talking about rates and these numbers. There are families being impacted. There are communities being impacted by these numbers. Late diagnosis is a very concerning issue for us. On the left side, you are going to see the late HIV diagnosis in Texas. 20% of new HIV diagnoses in Texas were late diagnoses. And
The question on the multiracial aspect, if someone is both Hispanic and some other race, how would that be counted?
so what we wanted to do was wanted to use public data. There is some disagreement about what constitutes multiracial and how you mix ethnicity and race based on census categories, based on CDC categories. What we wanted to use is the public data that we can have as a baseline for a better understanding. We need to go deeper into that intersection between race and ethnicity. We want to look at the patterns within each county in Texas, the different compositions in terms of race and ethnicity in each of the counties. When you thinking about the border, the racial composition is going to look very different from Houston, where you might have a larger influence of South Americans, or Central Americans, and Puerto Ricans, versus somewhere up in Lubbock, where you might have a population that has been since way before Texas was part of the Union. I hope I answers that question. So we need to go deeper in detail in each region about what multiracial means in each particular region. Going back to the late diagnosis, over 50% of the late diagnosis happen among Hispanics. Those numbers are pretty high. And when you compare the late diagnosis in Texas with other states, on the right side, what you see is only Hispanics. When you see the late diagnosis, about a quarter, one in five of the new HIV diagnosis is a late diagnosis. That has serious implications for the long-term health of the people who are newly diagnosed. That has implications in terms of the comorbidities, in terms of the urgent care needed. And also it has implications for HIV transmission. So this is an important indicator of how we are doing in terms of HIV. As I mentioned before, there is great variation across the counties, and sometimes we forget that we need to do a better job at understanding the local context in which this new HIV diagnosis happened, because there are different public health infrastructures, and we are going to see soon talk about that more. But the great variation across counties, the columns are the number of cases and the diamonds are the rates. I want to point out something on the right side, which is Lubbock County. It's a more rural community on the northern side of Texas. Even though the cases is 25, the rate is higher than other places, than other counties. These are 25 new individuals who have been diagnosed and whose families have been impacted, and that communities that are impacted. So we want to balance between understanding the magnitude in terms of numbers, but also the impact in terms of rates. And that's very important that we don't forget that there are small communities with fewer cases, but it's still higher impact. What we are seeing in terms of the increase that you saw earlier, in terms of the increase of new HIV diagnosis for Hispanics as a group, it's also happening for every category. Here you can see the increase for female and males due to heterosexual contact, and also IDU. And once again, I want to stress that these are long-term trends. There is not something that has been happening in the last few years. What has happened in the last few years is the spikes that we are seeing. This is about HIV diagnosis among men who have sex with men, among Hispanic Texans by age. And I want particularly to point out the huge spike in people 25 to 34, followed by 13 to 24. In other states, you can see that the 13 to 24 is lower than in Texas. So this raises questions about the health education, the sexual health education, the sexual health promotion that is done in the schools, in our schools. Testing and PrEP. On the left side, you see data that comes from the behavioral survey, and we wanted to highlight a few elements there. This is people answering the question to ever been tested for HIV. So in Harris County, you have over half who disclose have ever been tested for HIV. Only half. But when you go to places like Hidalgo, you're talking about 35%. So we have to increase access and utilization of HIV testing technologies. And on the right side, you see PrEP coverage, another tool to reduce HIV infections. And you can see, even though there was an increase in PrEP coverage over the last 2 years, what we have seen is a decrease. And this, we are here highlighting Harris County, but the same story happens in every of the counties that we look at. And going farther than that, when we have been looking at data for Florida and Georgia, the similar pattern is showing up. And another pillar of our HIV, the ending of the epidemic, which is the HIV continuum of care. Here we have receiver care and viral suppression. We sorted them by receiver care. And on the left side, you have Travis County, Austin, and on the other side, you have Webb County, Laredo. There is great variation across these counties. This variation is not necessarily a reflection of the work that the HIV workforce is doing. They are doing incredible work everywhere we visited, in the 10 counties that we visited. There is tremendous efforts and awareness of the impact of HIV in the Hispanic communities. What this chart represents is the socioeconomic and public health infrastructure inequities across these counties. And we are going to be seeing that soon. So in order to address the pillars of the ending the HIV epidemic that we mentioned before, like testing, like PrEP, like prevention, like engagement in treatment and achieving viral load, we need to understand the local context in which those cases are happening, the new HIV infections are happening, in the places where people are not achieving viral suppression. And here you can see, for instance, that overall there are dramatic drops in terms of receiving a care or viral suppression, an indication that there are other things happening in people's lives. There are issues of housing, poverty, access to health insurance. So again, this is not a reflection of the work that workers are doing on the field, on the trenches, on the street, but a reflection there is something deeper going on across all these counties. So that's going to be what we are going to be looking at next. This is educational attainment among Texan adults and comparing Hispanics to non-Hispanics. 56.3% of Hispanic adults have high school or less. Though that has serious implications for the kind of employment that they can obtain, for the level of income, for understanding the information that we are providing. And the important one is income, and we're going to see that soon, because when we're talking about health, sometimes health is a priority below housing, for instance. So when we talk about language justice also, it's important to understand and to acknowledge that sometimes the information that we are providing is not adequate, appropriate, or relevant to the people that we are serving. We were in Lubbock in a focus group, and this young man who said they want to educate us, and we cannot even spell educate. And he didn't mean that he didn't know how to spell literally educate, but that there was a disconnection between the information that we were providing as service providers and the information that the community needed. On the other extreme, you have only 5.9% of Hispanic adults with a graduate degree. That has serious implications for the availability and appropriateness of the current workforce. This is about economic stability, and we heard everywhere we went to that housing was a primary concern, sometimes below health, the issues of not having insurance, not having employment, the issue of trying to get the kids into a path that will lead to education. And we were reminded early on that people don't drop out of school, that sometimes people stop going to high school because there are pressing family issues. We were in San Antonio, I believe, where a woman talked about having 10 siblings who never finished high school, and she was the first one to go. And she spoke about how those 10 siblings worked hard so she could go to school. So they stopped going to school because the family needed someone to take care of it, but they also worked so she could go to school. And that story is very similar across many of the regions that we visited. People making decisions about what's important in their lives. This is the percentage. Some of you might be familiar with the poverty levels, which are absolutely ridiculously low. But let's assume for a second that that's what it is. The federal poverty levels. One adult and two children at $23,000. And what we want to show on the right is Travis County, one of the wealthiest counties in Texas. That's where Austin is. And as you saw in the one before, Austin has the highest income for Hispanics. And on the bottom, you have the border. So when you think about that, when you think about one of the wealthiest cities and counties in Texas, and you still have 15.3% of Hispanics living under the poverty level, that means one adult and two children living under $23,000. Uninsured. And that's a tricky one because we tend to forget that at the entry point of any health service we need to make sure that the person is going to have access to care. Some people told us, what's the point of getting a diagnosis when you don't have insurance? And not only a diagnosis about HIV, but so often a diagnosis next to a comorbidity. Issues of mental health, substance use keep coming up. In Texas, about a quarter of Hispanic Texans are uninsured. And if you look at the chart, most of the counties are above the US level, and several counties are over the Texas average. And those are the lines that you see there. But we also need to go deeper into what this means, and because the local contexts are important. And here you see the uninsured for Lubbock County. And this is important because 90% of Hispanics in Lubbock are US born, and 3% are foreign born naturalized. So we're talking about 94% who, in principle, are eligible to all these health services. Yet, you have on the chart, you can see on the left, you have close to 10% of Hispanic boys uninsured and 9.3% of Hispanic girls being uninsured. That's unacceptable. And then when you think about the middle, which is our workforce, the people who are supporting their families, the people who might be going to school. That means that these are the people driving our communities. And yet again, you have 1 in 5 Hispanic women not having health insurance. That is going to limit any kind of work that we can do in terms of preventative health. And we know the importance of looking at context, because when you look at the context in Lubbock, in which there are all these people who are eligible for care or insurance, but then you look at other parts on other parts of the county and other parts of Texas, where the conditions and the numbers are different. So we need to look at the local context. And finally, we are going to see a few charts on public health infrastructure. We are running a little bit these slides because we want to open up for conversation. The public health infrastructure. These are the suicide rates among Hispanics in the selected Texas counties. We don't have information for every county, and there is information missing for some years for some counties. And that's in itself is a data find, because this is public data that should be available for local jurisdictions to make decisions about how to invest in behavioral health or how to allocate resources in pressing issues. And the suicide rates have gone up across all counties. They are still lower than the Texas average, which is the line on red for all Texans, but the dotted points are for Hispanics. So in many ways, sure.
Can you make sure you, if you have a question, to type it into the Q&A chat, so that way if you have any questions, we want to be prepared to answer them.
Great, thank you, Evelio. So this is suicide rates, and what we wanted to choose in terms of mental health, we want to show the extreme. But behind this chart, there are all kind of issues of undiagnosed depression, undiagnosed schizophrenia or bipolar disorders, all kind of stuff. And what we heard in the assessment that we did in terms of mental health, stigma and literacy, is that there's still a lot of work that needs to be done to address the stigma and increase health literacy in our communities. And that also is challenging when you have, as you saw before, you have a high percentage of people who finish high school or less. And this is drug-related deaths among Hispanics, similar story. You see the trend going up for most of the counties. And this is important because sometimes we think about substance use in Texas as particularly key or an area of concern for the bigger cities like San Antonio or Houston. But you see these charts is happening across all counties. It means smaller communities and larger communities. It means in the rural areas, but also on the border. It means in larger metropolitan areas like Dallas, but also in places like Harlingen or Brownsville. This one is a chart that goes deep into the frustration that many of the people who do this work are expressing in all these last 3 years that we have been visiting every single county. It's a frustration because they work so hard to identify some comorbidities. So they work so hard with the clients to identify what are some of their health concerns. And yet, there is no an available workforce to address the need. This is Webb County, this is Laredo, where, for example, you have a licensed psychologist for every 25,000 people. Or where you have a licensed clinical social worker for every 28,000 people. There is nothing that you can do in order to address all the needs that the clients are bringing. So it's no surprise that sometimes our HIV outcomes are not what we want to, even though we work so hard. Because if you want to get an appointment for mental health, then you have to wait 6 months. And that's assuming that you have insurance. And that's assuming that you can travel from a rural area to the small town where there might be one licensed psychologist. We also wanted to highlight Travis County because even though Travis County has a better rate for population to health professionals, it's still unacceptable that you have a community health worker for every 3,400 people. These are community health workers that are doing HIV work, that are doing diabetes work, that might be going into neighborhoods trying to increase cancer screening. And on top of that, they have to contend with the fact that they are part of the population most impacted as well. This is the other part that we want to highlight, and we want to show this for a particular reason, because there are local medical and health schools in some of these counties. They are producing a workforce, maybe not at the levels that we want, but these counties are not living in isolation. They are interconnected. So we heard the stories of many of the young professionals who came to our meetings and focus groups and listening sessions and answer our surveys that if you went to school in Hidalgo or Cameron, then you have to make a decision where you want to continue your professional development. And sometimes it's not going to be in Cameron or Hidalgo. You might want to you start thinking about moving to the larger cities where you are going to have a higher income, as we saw earlier. You might have access to health insurance, as we saw earlier. So people are making the decisions. And this is important in the sense that we need to ensure that the workforce that we develop stay in the regional areas. We need to increase our workforce, absolutely, but we need to ensure that our workforce remains where it's needed. So when we presented this information, it was dispiriting and disheartening. And we saw in people's faces during these regional meetings how frustrating it was to see these numbers and to see their countries reflected in the big picture with other countries. And it was for us a moment to acknowledge the great work that they were doing. The health departments in Laredo or in Lubbock, our partners in Houston with the Ryan White programs that are doing amazing, amazing work. It was also a moment for us to say that we were able to identify where the gaps are, where the areas for improvement are. And we asked them in these meetings about recommendations to enhance the local work, but also to think about Texas as a whole, because how these countries are interconnected. Their economies are interconnected. Their families are interconnected. We often present in one county, for instance, in the Rio Grande Valley, and people will talk about their families and their coworkers up in San Antonio or Dallas. So these are counties are interconnected. So we ask them recommendations at the local level and at the statewide level. And that's what we are going to be talking about now. We are going to be showing some of the recommendations. Next year, what we want to do is go back, drive another 3,500 miles across Texas, we visited 10 countries, about 25 cities, and we want to listen to what people have to say regarding improving the system. So I know this is a lot. It looks like a lot on the screen, but it's just digging the surface, beginning to scratch the surface. We need to go deeper into what this means. So at the service and institutional level, people talk about maximizing enrollment in currently available health benefits and insurance programs. And that is important, that we can depend only on the clinics to do that kind of work. We need to ensure that communities, we partner with communities to increase increased access and enrollment in these benefits that are available. That means partnering with churches, partnering with housing programs, partnering with cancer prevention programs. And as we saw in some of the regions where we travel, people were started talking about environmental health as in a place of getting partners. Expanding access to HIV, STI, HCV testing. And this is important because there are many organizations doing that work and sending home tests. There are websites that provide that, but we need to scale that up. We need to ensure that I can go to a pharmacy and pick up a free anonymous HIV test, but also an STD test. There is a crisis in terms of syphilis in some parts of Texas. So this is the point in which we can do what we did for COVID-19. Provide quick, rapid access, anonymous access, free access to these testing kits. The other part is also we need to ensure that we have rapid initiation in the latest PrEP and ART treatments. And I'm just going to skip some of the recommendations. But it is unacceptable that in one of the countries that we visited, and the person from the health department told us the story of someone dying of AIDS, even though this person had access to care, even though this person was being treated, but she was older. So all kind of assumptions we made about her. So she was never tested for HIV. She was tested for many other things and treated for many other things. So we need to ensure that we have testing and rapid engagement in PrEP and HIV treatment. The role of non-clinical social service organizations, we talked about that before, but we need to ensure that we engage them, particularly to reduce the mistrust in the current healthcare system. We need to leverage digital health technologies. That means increasing digital literacy, but it will also means that the coverage, delivery, and reimbursement for preventive telemedicine services is available to these organizations doing the work. We spoke with some organizations who started doing telemedicine during COVID, but then they have to stop because they were not reimbursed anymore. So we need to ensure that we continue leveraging those digital health technologies and establish a endemic and preventative approach to behavioral health. We have been talking about endemics for a while. We have been talking about comorbidities. So it is important that we actually act on that approach, that we really fund programs that look at endemics. For instance, that means that we have to provide flexibility for integrated services to the populations. And finally, larger scale recommendations came up, statewide recommendations. And one of them was boosting the funding for HIV prevention and sexual health. You saw the shortage of workforce as a Texas as a whole. If you go to our socioeconomic profile, you can see the shortage in the high school system. And it's the same. We need to ensure that we fund properly HIV prevention and sexual health. Understanding that there are going to be regional variations in the public health infrastructure as you saw. We need to strengthen the behavioral health workforce. In particular, we need to ensure equitable compensation for Hispanic community health workers, recognizing their cultural and linguistic skills. We heard about how some of the work being done by these community health workers is not reimbursable. It's seen as outreach, it's seen as just an entry point, and sometimes those services are not billable. So we need to ensure that our Hispanic community health workers are compensated and recognized for their cultural and linguistic skills. And the last two are quite important, and they are big in the sense that we are talking about a state that is very diverse within, in terms of communities, but also that it has the energy and power and has done it to create equitable public health infrastructures. We need to fund HIV service organizations to become federally qualified health centers. In many places, that's the only option for the communities. And we need to ensure that happens in medically underserved areas and for medically underserved populations. At the larger scale, like in Houston, but also in the smaller scales around El Paso. We talk when we were in El Paso, we talk about how some of the cities next to El Paso are struggling to ensure services because they don't have health departments. They depend on the health department in other places to provide those services. We also need to ensure that Texas embraces the Affordable Care Act's Medicaid expansion. Um, it's a long shot, I know, um, but we also have to ensure that we ask for something big. Finally, thanks to the staff, our partner organizations in these 10 Texas counties who welcome us and join us for the past 3 years, and they have shared their challenges and successes with us and made recommendations to improve the Texas health system and address the needs of Hispanic communities. And
So there's a couple of questions in the Q&A from Joey Lopez asking about the ADAP program in Texas. And then there's a second ADAP question from Francisco Diaz about whether it's similar to New York State and where there's a health insurance premium program. We do have those here in Houston, and the Texas State Health Services manages ADAP. The last couple of years, right after COVID, they were backlogged. So people had to wait a very long time to get their ADAP application approved. So they were without the approval. And there's certain jurisdictions that do have a local pharmacy program where the fairly qualified health centers can provide those meds, even though their ADAP application hasn't been approved yet. We do have a health insurance program also that is managed, but it's still, it's not as efficient as I think it should be, but it's almost going, a lot of money is going into it. Insurance premiums and are going up in Texas at an astounding rate. We constantly have to reallocate money to that program. So we have our challenges in Texas, but as you can see, we are constantly adding new cases, and now they're spiking. So we're adding new cases to the caseload for case managers and for doctors, but the funding kind of still remains a little flat.
yeah, right. So this is the other challenge because on the one hand, Ryan, why our funding has been flat. The other thing is that even though we understand that ADAP programs like ADAP are very important, we also need to make sure that people have access to health insurance. That depending on the ADAP program, as it should be as it was intended, the last resort. But for many communities, it's becoming the only resort, and that's a challenge. So we need to ensure that we have access across Texas for health insurance, that there is a workforce available to address their needs. And again, just repeating myself, we need to ensure that the people have access and options. And if the only option is waiting for the pharmaceuticals to approve your PrEP, that's a challenge. If we are relocating all the efforts of HIV testing, health literacy in the clinical settings, in hospitals and clinics, we have to acknowledge that there are issues of health literacy. We have to acknowledge that there is a mistrust in the health system. So I don't think there is a one solution or a set of solutions without understanding what the context is, what the local infrastructure looks like. Because as you saw, maybe in many cases is no access to it up. That is the challenge. In many places, it's actually that your health is the lowest, is in a low priority. In many cases, it's substance use and mental health that you cannot have appointments, that you cannot get services. or that you cannot pay the copayments every week for therapy.
I have a question. First of all, thank you very much, Daniel, Evelio, and Rosana, for doing this amazing job. Hearing what you just presented give me a broad view of what's happening in the South, and especially in Texas, because when we started to do this campaign, we tried to focus on treatment, right? And then we discussed why are the factors that why Latinos are not getting treatment for HIV. And now I'm seeing a different perspective from a different area where I don't live at. In New York, it's different. And so it was kind of shocking to me, like to learn that in some of the counties you presented, a big, almost 100% of Latinos are born in the states, so they have access to every single insurance and the system that they should be able, but they don't do it. So it was really shocking for me to do that. And the other thing is, I wanted to ask, do you think that being in the border of the country with Mexico, does it affect the towns or the cities around the border, like El Paso, Laredo, that are not receiving the same attention that Houston is receiving, for example?
Absolutely. And then I'm going to give it to Evelio and Roxana, but absolutely. And I think one of the misconceptions in terms of the border towns is that they are overwhelmingly immigrant communities. They are not. These are communities that might be binational, might be commuting, work, home, shopping across the border. But there are many communities along the border who are underserved, whose income is so low that is draining the workforce towards places like San Antonio or Houston or Dallas. Evelio and Roxana, please dive in.
Well, I think the issue with the border, I am from the border. I'm from a very famous town. It's Eagle Pass, Texas. You know, it's constantly being used as a political prop. But you do see the challenges in the border because you see a lot of new people that are going off to the bigger cities, to other communities. You know, they want a quality life also as part of the workforce, and they want advancement in their lives. So, I mean, I don't blame them, but at the same time, there is a huge need alongside the border. And when you have new services and they're already stretched very thinly, we really need to pay attention to emergency responses when it happens in the border. We can't get it. The border cannot be ignored. So, I mean, and I said this during Lubbock, you know, both people on both sides are upset. I understand that, but we have to have a conversation to really come together and solve the problem. And when these communities have high need at that moment, at that time, we really need to respond adequately. And so I feel the pain on the border. You know, sometimes people say, well, you know, there's certain, you know, 7,000 immigrants in a certain city, but then, you know, Laredo, I mean, or El Paso gets 10,000 immigrants per day. So, but the idea is that they're not going to stay on the border. They're going to move on to other places. So that's the idea, is we need to really have a humanitarian approach to these situations, and then also having sympathy for those who actually live there on the border. Roxana, did you want to add something?
Sure. So I wanted to add like two little narratives when it comes to communities along the border. So looking at some of the data across all these counties, we see that actually the foreign population doesn't stay at the border. We see larger percentages in Dallas County, Harris County, especially close to 40% are foreign born, and about, I believe, 28% in Dallas County was foreign born, not a citizen. So that's one story, right? That those who probably do immigrate into the country, they do not stay at the border. The other side of the story is that those that actually stay in the border, and this is from some of the interviews that I had a chance to interview some of the people, older individuals living with HIV. These individuals, when accessing services, they tend to interact with Mexico. So if they can't get some of the services or if they have to wait for a long time, they actually, for the flu or for any other service beyond HIV, they go they go to Mexico to treat for that fast treatment that they want to receive, because here in the US they do not want to wait in those long lines. And as we mentioned before, those cities along the border have that constraint of a shortage of the workforce, right? So I just wanted to point that out.
Giovanna Quiroz is asking a question about stigma as it relates to cultural views. This is something that we found in the behavioral health assessment. Do you want to talk to it, Daniel?
Yes. So on the one hand, we need to do a lot of work in terms of the stigma, whether it's connected to HIV, substance use, and mental health, which are kind of the primary correlated issues driving HIV. So we still have a lot of work to do with the stigma. I just want to highlight someone who said in one of the meetings, who said, I don't get the chance to be stigmatized in a clinical setting because I don't have insurance and I cannot go to the doctor. And that struck me as something about the hierarchy of needs, in the sense that this person said to us, I don't get the chance to be stigmatized. And it's with that sarcasm that tells me where the priorities are and how we need to do both at the same time. We need to ensure that we reduce the stigma, but we also need to ensure that people have access to those services. And it's something that needs to be done simultaneously. The one piece I also want to add, and I don't know if I answered the question, but yes, we saw the issue of stigma everywhere we went to, and in connection also with access to care. The piece that we want to mention is that, and I put that, you can see the new HIV diagnosis and rates by county there. These counties are interconnected. So there needs to be statewide policies that address these issues. And at the same time, simultaneously, we need to understand the complexities of every location. We're talking about tuberculosis becoming a health concern along the border, and it is a health concern along the border. And then we went to Lubbock County, in which they talk about how that was not their main concern. There are intersections that happen at the local level that are not captured in a statewide policy. For instance, in El Paso, we were reminded that many people have health insurance or use services across the border, as Roxana was talking about, binationalism. Those are the local contexts. We need flexible funding, either from the federal level, the state, or local level, that allow the organizations to be creative, to be innovative, because they understand their communities, to know if the partnership needs to happen across the border, or in places like, they say, Lubbock, the partnership needs to happen with other service organizations outside of the HIV field. But there has to be some level of flexibility and direct funding for integrated healthcare, integrated behavioral health. Veli, you want to say something?
Yes, question that kind of follows up what you're just saying. What would you suggest is the best way to involve and connect on the larger level with HIV prevention work, and how can professionals support you in the mission directly and indirectly? I think this is super important. Empathy for HIV and HIV philanthropy, and then also the involvement of state and local jurisdictions to actually allocate money besides federal funding to the cause. That's something that also at a local level, local jurisdictions need to put a line item in their budgets to support HIV prevention. Also the state, and then also philanthropy itself HIV giving is going down, and we need to really look at addressing that. So as professionals, we need to make sure that we are donating and giving to those agencies that are working on innovative approaches.
Yep, and we put here some recommendations that came out from our work. We really need to take the idea of syndemics very seriously, and we need to take the idea of preventative behavioral health seriously. That means that there needs to be integration, not only in the service provider, but also that the health system that we have is integrated. Which means that the health departments need to be supported to integrate those behavioral services within their jurisdictions. That also means that the federal level need to see how all these different agencies that are addressing cardiovascular disease and diabetes and cancer and HIV, mental health, substance use are interconnected, are integrated, that they talk to each other, and that their funding is, again, it's flexible enough to understand how these health issues interact with each other on the ground.
Any other questions or comments?
I was going to say at 3 p.m. we have maybe a little more time for questions, if there's any question. I want to thank you, Daniel, Evelio, and Roxana very much for the presentation and supporting NLAAD. I also want to add, NLAAD, National Latinx AIDS Awareness Day, is still a need as we are doing it because, as you can see in the presentation that we have, many people are not informed or aware of the resources that we have available now to end this epidemic. And it's important for us to distribute in a cultural and sensitive way the information to people like those living in Texas that we just have seen in the presentation. And also, I wanted to ask, do you have plans to do this in different states in the South?
So we have done some of the work in the South. For instance, we did an assessment of mental health and substance use stigma health literacy in 7 states in the Deep South. We didn't include Texas and Florida because we wanted to pay more attention or deeper attention to the specifics of the 7 states within the South. We are developing a similar health and socioeconomic profile for Florida. We have chosen 6 counties in Florida. We want to start looking at how those particular contexts influence and impact health outcomes. Then we are also looking at how the work that we are doing in terms of integrating HIV and aging services, the work that we are doing in Texas regarding this, is applicable to other jurisdictions. For instance, we had Evelio presented this work in Chicago, and the same idea of how we pay attention to local context and what's happening in the local context. We are also we're very interested in continuing our work in Georgia. So these are some of the Latino Commission on AIDS has a program called Latinos in the South. So we have been partnering with Latinos in the South to ensure that we focus on deeper our work in every state, but also understanding that the realities in Georgia or Alabama or Tennessee are very different from Florida. Even within Florida, we have been finding that Central Florida looks very different from Fort Myers or Miami, the Miami-Dade area. Yeah. So again, I think the message is for us is that there needs to be more work by other partners or other organizations to go deeper into the local context.
Yeah, I would say also please visit our website at ilhe.org. A lot of our publications, our reports, our health equity briefs, and please keep in touch with us, and we did equity briefs on diabetes and then on cancer. There's a mental health one that's coming up soon. And we're working diligently on a national HIV and Hispanic profile also as well.
Well, thank you very much. And again, asking the organizations in Texas or in the country to continue supporting NLAAD, doing the events and creating areas or events or meetings where you can promote prevention and also testing. And that's important part of us, like a community, we can do, right? Support the people that's working in health already, to promote and educate the population about these resources, which is very important. As we can see in Texas, many people who have access to health insurance, they're not using it. So those type of things we can start doing and promoting, again, prevention, treatment, and staying on treatment, which is an important part of the pillars during this epidemic. So we have 3 more webinars. The next one is with Dr. Annalise Roque from Emory University in Georgia. And so she will be presenting about treatment of HIV. And then we have next with the value, which is going to present about integrating aging in the HIV care. And the last one will be with AceView, presenting about trending for the HIV care cascade in the country. So hopefully we'll see you guys again, definitely again, in 2 more webinars. And everybody who is attending today, I would love to have you attending the other webinars as well. So thank you very much for everything. Thank you very much for NLAAD, and see you soon.
Bye, everyone.
Bye-bye.